All right, class. So I know where I am supposed to start now on slide 21. So we're not too far from finishing this presentation. The next topic we will deal with as it relates to pain is physical dependence, tolerance, and also addiction. Now, physical dependence means the normal response that occurs with repeated doses of opioid several days or for several days. These patients, they develop withdrawal signs and symptoms when these drugs are suddenly and abruptly reduced. So not only when the drug is reduced, but also if Narcan is given, because remember, Narcan actually blocks those receptors. And so when the opioid cannot stimulate those receptors, then it actually reverses the effects of opioid drugs. So this puts them in a kind of withdrawal as well, because you're taking away the effects of the opioid drug. The other term here is tolerance. What is tolerance? So it is a normal response that occurs with regular administration of an opioid and consists of decrease in one or more effects of the drug. So it could be a decrease in the effectiveness of the pain medication. The medication not working, is not bringing about a pain relief. So tolerance occurs within the first days to about 2 weeks of treatment. Now, this can be avoided by increasing the dose or rotation to a different opioid. So you either have to increase the dose of, let's say, morphine, or you have to switch it to another pain medication or opioid. Then you can get, or you have a decreased chance of a patient reaching a tolerance level. Now, opioid addiction, this is a chronic neurologic and biologic disease. It is influenced by genetics. Some people, due to genetics, they may have some family members who are easily addicted. It has to do with genetics. There's also the psychosocial component, environmental factors. No single cause has exactly been identified, but these are the few that scientists apparently have discovered to be the culprit. It is characterized by one or more behaviors: impaired control over drug use, compulsive use, and also continue to use despite harm or craving. But it leads to a treatable disease. It can be treatable. Now, you also have a pseudo addiction, which is mistaken. It's a mistaken diagnosis of addictive disease. It occurs when someone has uncontrolled pain that is not treated very well or undertreated. These patients, they manifest signs and symptoms of an addictive disease. For example, a patient being very demanding about opioid medication request. If the pain was actually treated properly, these pain behaviors will decrease. So sometimes when you have these patients who are really demanding, they want their pain medications right now, and they're on the call bell constantly. It's not that some of them, or perhaps many of them, for that matter, are addicted to these opioids. It's just that we're not really treating their pain properly. Turn this phone off. Go on silent. Let's see. So the next slide here is we're dealing with some of the common side effects of opioids. We have constipation, nausea, vomiting, pruritus, which is itching. We also have sedation, and respiratory depression is less common, but it is most feared. Someone stops breathing, that can be a major issue. I would like for you to take a look at the drug alert yellow box on page 59. It talks about these, I think that's the one that talks about the side effects. Let me double check. Oh, well, this one actually talks about modified release opioids should never be crushed, broken, or chewed because doing so alters the formulation of the drug and can result in adverse events. So make sure you take a look at that. Any sustained release drugs you never want to crush or chew. They're supposed to be taken whole because it releases the drug over a slow period of time. Otherwise, if you crush them, then you're getting a much more faster or increased dose of the pain medication, which is not good. Read also page 59. There is a nursing focus on older adults that deals with pain. Take a look at that as well. It's on page 59. It's about older adults and pain. Remember, these are the populations that we will deal with mostly in the hospital. Let's see. Also take a look at these common, there's some common side effects. Actually, all right. Anyway, so consider the common side effects that we just mentioned. Also take a look at page 62. There's a drug alert. The drug alert's on the yellow box, by the way. This one talks about fentanyl. You certainly need to know about fentanyl because this is what they are lacing heroin with, making it more powerful. And this is what is actually killing a lot of users. Also take a look at page 62, table 4-7, about ways to prevent opioid side effects, such as constipation, nausea, vomiting, and sedation. I think I more or less talked about this earlier. For example, with constipation, they may prescribe the patient with a stool softener. Is that a page 62? I don't know why I did this, but that's actually page 63, table 4.7. I must have really been in a rush. Let's see. So it's page 63. So for example, with constipation, assess previous bowel habits, keep a record of bowel movements, remind patients that tolerance to this side effect does not develop, so a preventative approach must be used. Administer stool softener plus mild stimulant laxative for duration of opioid therapy. Do not give bulk laxatives because these can result in obstruction in some patients. Also provide privacy, encourage adequate fluids and activity, and give foods high in roughage, like your vegetables. If ineffective, try suppository or Fleet's enemas, and so forth and so on. It talks about respiratory depression, nausea, vomiting, sedation, and some measures that you can take to minimize these problems. Under respiratory depression, it talks about stop opioid administration immediately for clinically significant respiratory depression, stay with the patient, continue attempts to arouse the patient, support respiration, call for help, consider the rapid response team or code blue, and consider giving Narcan. So yeah, so take a look at that, very important information and how you would manage these side effects. And the next slide here, I need to increase my size on that one. The next slide here deals with adjuvant analgesics. And this will consist of your anticonvulsants and your antidepressants. As far as anticonvulsants, it produces analgesia by blocking the sodium-calcium channels in the central nervous system, thereby decreasing the transmission of pain. So that's how this medication works. And then there's also your local anesthetics. If you look on page 63, I think, and that might be wrong, page 63. Yeah, so on page 63, there is a critical rescue box that I would like for you to look at. Always look at these boxes, by the way, even if I forget to tell you to look at them. Tables, charts, boxes, and so forth, take a look at them. But this particular box, the critical rescue deals with vital signs as well as opioids. Talks about watch the rise and fall of the patient's chest to determine depth and regularity of respirations, in addition to counting the respiratory rate for 60 seconds. For accuracy, respiratory assessment is done before arousing the patient or the sleeping patient. So you want to assess their respirations before you awake them. If a patient is difficult to arouse, always stop the opioid, stay with the patient, continue vigorous attempts to arouse, and call for help. And that's pretty much the same that they've taken out of the other box. So take a look at that. Some of the medications that the anticonvulsant or these other medications that deals with your neuropathic type of pain, your gabapentinoids, which is Neurontin, and also Lyrica, recommended as a first-line analgesic for persistent neuropathic pain. All right, so when we talk about first-line analgesics, it's the first thing that we typically treat a patient's condition with. These drugs are increasingly being added to post-operative treatment plans to address the neuropathic component of surgical pain. It deals with pain, a different mechanism, if you will, but as opposed to your other analgesics. The primary side effect are sedation and dizziness with these medications. Now, antidepressants relieve pain on the descending modulatory pathway by blocking the body's uptake of the inhibitory neurochemicals, norepinephrine and serotonin. And that's actually going enough there. All right. Now, antidepressant adjuvant analgesics, are divided into two major groups. You have your tricyclic antidepressants, or tricyclic antidepressants, or what we call as an acronym TCAs, and the newer serotonin and norepi reuptake inhibitors, or SNRs. The most common side effect of your TCAs are dry mouth, sedation, dizziness, mental clouding, weight gain, as well as constipation. Older adults are often sensitive to the effects of the adjuvant analgesics that produce sedation and other CNS effects, such as anticonvulsants and antidepressants. So they're very sensitive to the effects of these drugs. Therapy should be initiated at low doses. Remember, their liver may not be working as well. Their renal ability to filtrate and to remove metabolic waste has diminished as well as they get older. So you want to start them off at a low dose and then titrate the medication slowly upward. And making sure that a systemic effect having any significant issues. As far as local anesthetics relieve pain by blocking the generation and conduction of the nerve impulse necessary to transmit pain. The local anesthetic effect is dose related as well. A high enough dose of local anesthetic can produce complete anesthesia, and a low enough dose, a sub-anesthetic effect can also produce anesthesia. So really be careful about that as well. CNS signs of systemic toxicity, once it gets, if it goes into your body system, includes ringing in the ears, a metallic taste, and irritability, and also seizures. Now, signs of cardiotoxicity include tingling and numbness, bradycardia, cardiac dysrhythmias, and also cardiovascular collapse. Some of the medications we use as far as the topical ones, lidoderm or lidocaine patch 5%. This patch is left in place for 12 hours and then removed for 12 hours. So it's a 12 hours on, 12 hours off regimen. All right. Topical local anesthetics, creams for superficial procedures such as an IV insertion can also be used. So they do have anesthetic creams. So if you need to start an IV, there are creams for that as well. There's also liposomal bupivacaine for post-op wound infiltration. This decreases the need for potent opioids. Then we have the regional anesthesia, which is administered by a single injection of peripheral nerve blocks using a long-acting local anesthetic such as bupivacaine and ropivacaine to target a specific nerve or nerve plexus. All right. Sometimes, like that, it kind of looks like a PCA pump, but sometimes they, I can't think of the name of them right now, but there's a device that looks like similar to a PCA pump, but it's smaller, and you actually hang it up on the IV pole. And they have this catheter. Let's say if someone had received a knee replacement or hip replacement, they insert this catheter near the nerves in that region, in that area, and they administer medication continuously to that area, and it blocks the peripheral nerve and thereby gives the patient better pain relief. Again, bupivacaine and ropivacaine are some of these medications that act specifically and directly and locally on that related nerve. Now, there's a continuous peripheral nerve block involves establishment by an anesthesia provider of an initial block that is followed by placement of a catheter, which an infusion of local anesthetic is administered continuously with or without a PCA capability. And actually, that's one of the things I'm actually referring to. The other one is more of an injection, but this one is more of a continuous infusion. So my apologies, I got those a little turned around. So the regional is an injection, but the continuous one is a catheter that is inserted right near the area where you want the patient to have adequate pain relief. All right, and then we're talking here about a placebo. A placebo is defined as any medication or procedure, including surgery, which produces an effect in a patient because of its implicit or explicit intent, not because of its specific physical or chemical properties. So in other words, a saline injection is one example of a placebo. So they may perform some kind of surgical procedure, or they may give a patient some medication that really doesn't have any chemical properties that would ordinarily bring about a therapeutic effect. but it makes people believe that what they're getting is effective. And the mind is very powerful. And if they think they're getting something really powerful, then it may have pain relief without the side effects, obviously. Read also page 64. There's a drug alert box regarding proper administration of Narcan. Definitely want to read it. Actually, yeah, so make sure you take a look at it. It talks about unless the patient is at the end of life, properly administer the opioid antagonist. It antagonizes the opioid. It makes it not work, right? So you give it IV to reverse clinically significant opioid-induced respiratory depression, because this is how these patients usually die when they overdose on heroin, which has fentanyl in it. Usually when the respiratory rate is less than 8 breaths per minute, or according to agency protocol. So make sure you read the rest of that information as well. And also read on page 65, there is another drug alert box regarding placebo. Now, this is very important. It says deceitful administration of a placebo violates informed consent law and jeopardizes the nurse-patient therapeutic relationship. Never administer a placebo to a patient. Promptly contact your nursing supervisor if you are given an order to do so. So there are some laws against that. I'm not sure if that's a nationwide law, but that, just so you do know that you don't just willy-nilly just go ahead and just give it to people. All right, they probably do it more so in studies and such as that. All right. And these are some of your non-pharmacological interventions. Should be used to complement, not replace, your pharmacological therapies. In other words, you give morphine, but you also give a massage or acupuncture and so forth. All right. It consists of physical modalities as well as cognitive behavioral strategies as well. Most people use self-management and non-pharmacologic strategies to deal with their health issues and also to promote well-being. Now, your non-pharmacologic methods are appropriate alone for mild and some moderate intensity pain and should be used to complement, not replace, your pharmacologic therapies for more severe pain. So if it's more severe pain, you want to use them together. But if it's mild, you can get away sometimes with just a non-pharmacological method. Research has shown that non-pharmacologic methods can facilitate relaxation and also reduce anxiety, stress, as well as depression, which often accompany the pain experience. All right, these patients, they usually experience these issues. Nurses play an important role in providing and teaching their patients about non-pharmacologic strategies. Right? And many of the methods are relatively easy for nurses to incorporate into daily clinical practice and may be used individually or in combination with other non-pharmacologic therapies. Now, non-pharmacologic interventions are categorized by as being body-based, in other words, physical modalities, or also mind-body or cognitive behavioral methods. As far as the physical modalities, in the acute care setting, physical modalities are used often because of their ease in implementation and their role in post-op recovery. Among the most effective physical modalities used to manage or prevent pain, we think about things like PT, OT, or occupational therapy, your aqua therapy in the water, acupuncture, etc. All right, and make some changes here. Other physical treatments are your cold applications, such as ice, your cold treatments, which we call cryotherapy, your TENS. This is TENS, all caps. This is some type of electrical stimulation device. And also spinal cord stimulation may be used as well. As far as the cognitive behavioral strategies, cognitive behavioral strategies, sometimes referred to as cognitive behavioral therapy, or CBT, is facilitated by a licensed psychologist or other qualified mental health professional. Now, cognitive behavioral strategies are useful in reducing the patient's focus on pain, but do not physically block pain transmission. All right, just takes their focus away from the pain. It's not doing anything physically in that sense. Instead, they help the patient adapt to challenges presented by the pain experience, such as anxiety and distress. Now, your cognitive behavioral methods range from simple, it can be prayer, relaxation, breathing, artwork, reading, watching television, to the more complex methods, such as mindfulness, meditation, guided imagery, hypnosis, biofeedback, and also virtual reality. There's also distraction. Distraction is probably the most commonly used behavioral or cognitive behavioral method. All of us use simple distraction measures in our daily life when we watch television or we read a book. All right. There is also detractors. There's also visual detractors or distractors. In other words, looking at a picture, watching television, playing a video game, it can divert the patient's attention to something pleasant or more interesting. There's also auditory distractors. In other words, listening to music or relaxation tapes can have a calming effect as well. We also have imagery. It's a more complex form of distraction in which the patient is encouraged to visualize or think about a pleasant or desirable feeling or sensation or event. Patients who practice this technique can mentally and vividly experience sights, sounds, smells, events, and or other sensations. So this is a little more complex. Then we have this last one, mindfulness, is similar to imagery, except that the patient focuses on his or her actual environment rather than imagining it. So, for example, in the fall, in an area where the tree leaves change colors, the patient focuses on the beauty of the colors to appreciate them. So, can be a good distractor as well. And these are some considerations for older adults. With respect to opioids, we want to always start off with a low dose and titrate slowly. We always want to do a systemic assessment of the patient's response, see how they're responding, but we're looking at it from a systemic point of view. Teach caregivers measures to reduce falls and accidents. And also home safety assessment is recommended, which your home care agencies will send a nurse out to do a home safety assessment. You know, rugs, these throw rugs that they can trip on, other things that make them injury prone. Help the patient establish an analgesic regimen that does not interfere with sleep, with their rest, appetite, or level of physical mobility. We want to ensure that patients are aware of any dangers associated with driving or operating mechanical equipment. So if a patient is working around equipment or in an area or type of work that they may maybe get disoriented, injure themselves or injure someone else, we want to make sure patients are aware of these dangers. Tell patients to ask their primary care provider when these activities are safe to perform. So their physician should be able to let them know when it's safe to participate. Older adults and others at risk for falls or accidents in the home setting may benefit, again, from this home safety assessment. Take a look at page 67 also for coordination and transition management section. These sections are very important, especially in terms of when you're taking your boards, your HESI, as well as your regular exams. So don't just throw off these sections. Again, this is on page 67. On page 68, the section that's entitled Self-Management Education and Healthcare Resources section, take a look at that as well, because teaching or health promotion is huge on your boards. So take a look at that. You have to know something about it in order to teach about it. So this is that TENS unit that I was talking about. I think I may have, oh, there it is. All right. So this is a TENS unit. This is the electrical device, and it sends these impulses. It's an application of a transcutaneous electrical nerve stimulator, and this is what is used at times to help patients deal with chronic pain as well. Right, kind of confuses those nerve pathways that are normally taken, and so thereby giving some relief. It's a little more in depth than that, but that's kind of the simple of a TENS unit or its purpose. All right. These are some cognitive behavioral strategies. We talked about this already: the prayer, relaxation, breathing, artwork, meditation, hypnosis, and virtual reality. So we've talked about that already. And let's see, we actually almost finished. As far as pain, pharmacologic therapy for your non-opioid analgesics, acetacyclic acid or aspirin and acetaminophen are most of the most common medications that are used. Most are NSAIDs, including aspirin. They are COX-2 inhibitors for long-term use. Now, your non-opioids are available in a variety of formulations and given by multiple routes of administration, even rectally. The non-opioids are often combined in a single tablet with opioids such as oxycodone or Percocet or hydrocodone, which is also known as Vicodin, Norco, and Ibuprofen, and are very popular for the treatment of mild to moderate acute pain. So when we talk about the non-opioid are often combined in a single tablet. So you have aspirin and Percocet in one. So the patient is taking one tablet, but it has both properties to do different things. Relieve acute pain, but in different ways. People with persistent pain also take a combination of a non-opioid and an opioid analgesic. All right. So acetaminophen and an NSAID may be given together, and there's no need for staggered doses when giving it. Now, acetaminophen or Tylenol and NSAIDs make up the non-opioid analgesic group. Now, acetaminophen is thought to relieve pain by an underlying mechanism in the central nervous system. It does have analgesic and antipyretic properties, but is not effective for treating inflammation. Now, oral acetaminophen, Tylenol, or Avenol has a long history of safety in recommended doses in all age groups and most patient populations. So this drug is typically safe. It is recommended as a first line for musculoskeletal pain, such as osteoarthritis in older adults, but it does not have any anti-inflammatory properties like your NSAIDs do. So your acetaminophen is less effective than your NSAIDs for chronic inflammatory pain, such as rheumatoid arthritis. Tylenol does not increase bleeding time, and it has a low incidence of GI adverse effects as well, making the analgesic of choice in many people in pain, especially older adults. And some of this is actually duplication, so I didn't create these PowerPoints. So NSAIDs, they do have analgesic effect, they have antipyretic effect, as well as anti-inflammatory properties, so times 3. These drugs produce relief, pain relief by blocking prostaglandins through inhibition of the enzyme cyclooxygenase, or COX, in the peripheral nervous system. And this is our last slide for this particular one. Here we get into community-based care as far as home management or home care management, self-management education, and healthcare resources. So help the patient establish an analgesic regimen that actually, I have already given you guys this, so we won't go over this again. I'm not sure how that happened. Maybe I just put them in the wrong section or slides before I knew I had covered them. All right, so disregard that one. Or just apply the one that deals with the coordination and transition management, the self-management education and healthcare resources. We can just apply that to this particular slide. So I need to just go back and fix that. I was told not too long ago that I'm taking over this class, and I've been trying to get it together with the short time that I do have. So I'm doing some of these weird things. So forgive me. Won't hurt. It won't hurt anybody, but at the same token, it's kind of duplication, if you will. At any rate, we are done with the pain management presentation, and I don't think there's anything else to be said about pain. There was a lot already said, but really pay attention to this section or this topic. Very, very important. And so I am going to sign off, and I hope you enjoy your day.